So let's move
Okay.
on to our panel discussion, which is the topic today is golden hour in psychiatry, which is not a universally standardized as in trauma medicine. So this panel discussion we hope to highlight to help us understand this topic. And I now hand over to Nirmala Srinivasan, who's the moderator for this session. To introduce Nirmala ma'am, I don't think she needs any introduction. We all know her very well, but even then, it is my duty to introduce. So, Nirmala ma'am is the founder of Families Alliance for Mental Illness, FACEMI India. She's an academician and Ashoka Fellow, has been in the expert committee of the Mental Health Act, a family carer, most importantly, and an advocacy expert. Over to you, Nirmala ma'am, to take the proceedings further.
Thank you so much. There seems to be some problem with my internet. I hope it
You're absolutely audible. You're absolutely audible.
You're clearly audible.
Please go ahead.
Welcome to the speakers and Dr. Krishna Prasad, Dr. Rajani and Sumit, Mr. Sumit Guha. Sumit, of course, I can call you Mr. Sumit, I hope. And we have a very, very high-powered panel, very competent and excellent panelists on this topic. Briefly to tell you, how did I get upon this? Why did I choose this topic? But the choice is not something very planned. It was more accidental. While we were discussing the ambulance norms and SOPs to be introduced and integrated with the current ambulance service in Karnataka. By the way, the ambulance service in Karnataka for persons with mental illness is one of the best, almost leading in the country, I should say. We are trying to fine-tune and tweak it a little more with all the SOPs. And in the course of the discussions, Dr. Rajani, who is here today as a panelist, we were talking to her and the Deputy Director, Ms. Dr. Prabhu. I don't know if he has joined. I requested him to join. While we were talking, it just struck me to ask them whether they give any first aid to the psychiatric patient who is in a crisis, who is in an emergency, for whom the ambulance has been called for. So the ambulance has arrived. The scenario, I request all of you to visualize. That was the scenario we were discussing. And then both Dr. Rajani as well as Dr. Prabhu said they don't give any first aid to psychiatric patients, which shocked me. Of course, it is equally a shock to them also. I understand. It's not that nobody wanted to deprive these patients, but it never struck anyone. And then I was wondering, why not this golden hour in psychiatry? Why are we missing that? First aid is being given in the same National Ambulance Services 108 to a cardiac patient, to a stroke patient. It is being given to an accident victim. Why not a psychiatric patient in emergency? A psychiatric patient in emergency is, many of us, we don't need to describe how it is or even explain what it is, but it is a public event, almost I can say so. It is not like others. So it is not, why is it being denied? That was bothering me quite a bit. And that's how this entire genesis of this topic, and has been working over it, came up like this. Many of you recently, just a few days back, you would have come across the mother and son in Noida who just jumped from their 8th floor apartment because they were helpless. The mother was helpless, late Mrs. Chawla. She didn't know how to handle this whole problem. I was wondering, could they have been saved had we had a more expansive, more versatile definition of golden hour in psychiatry? Why are we ignoring it? Because in psychiatry, it is far more, the ramifications are not just medical. It's not just disability, permanent disability or death or whatever we call it. Ramification much more. The victim may not die, but the memories, the family's tragedy, the trauma, the stigma, these are some things which we cannot ignore. And therefore, I realize that we need even DSM-5, which is the classification used by American Psychiatric Association in 2013, does not define golden hour. At the same time, it says it is only trauma care, nothing beyond trauma care. So, for the first time, we have something of golden hour within the framework of psychiatry, within the framework of psychiatric services, but restricted only to handle patients or victims of trauma, what they call as PTSD. But we have many more situations. For example, if a person has an accident with him, blow on his head, he goes and admits himself to the emergency in a hospital. Immediately they start whatever emergency procedures are. But I'm sure all of you will agree with our loved ones who are under treatment live with different types of blows through the day, different phases, different kinds, blows, quote unquote. Why don't we realize that? And sometimes these blows becomes unmanageable. We seek admission in hospitals, we go to emergencies, admission is denied for involuntary patients. That is something which is very traumatic. I know 2 cases in Bangalore, and they are in this program now. I can see them in the program, who had to run from hospital to hospital because they said involuntary patients we don't take. This is another new development. Involuntary admissions are also trauma cases for us. Considering all this, I said, why don't we have this golden hour concept? Why don't we examine it more thoroughly? Is it only medical? If it is only medical, is it only trauma care? Or does it apply to other psychiatric emergencies also? How do we handle this? These are the questions that we bothered. And so I was very happy to have these panelists who agreed to join us today. And the first panel member, is Dr. Rajani here? Dr.
Yes,
Rajani,
ma'am. Yes, I'm there.
Director from Govt of Karnataka, Dr. Krishna Prasad from NIMHANS, and Mr. Sumit Guha, our FACEMI member. All the three are there. We'll start with Dr. Rajani because she is in a bit of a hurry to join, and she's come out of one meeting, in fact. Thank you so much, Dr. Rajani.
Thank
Dr.
you.
Rajani, currently Deputy Director, Mental Health in the Directorate of Health and Family Welfare, also Medical Advisor to Karnataka State Mental Health Authority. She has a diploma in psychological medicines and MBA in human resource management. She has had several positions, such as psychiatrist in the Department of HFW and in Central Prisons, Karnataka. I cannot enumerate the assignments she has had in such a short span of time. And it's amazing how a psychiatrist could do so many. She has been instrumental in initiating several projects, most important of which is Matru Chaya project, brain health issue, training medical officers, suicide prevention and addiction programs. Most important among these, the pioneering home care doorstep delivery of services to families inspired by FACEMI assisted home care was also started by was also initiated by Dr. Rajani on behalf of Government of Karnataka and piloted by NIMHANS. Besides all this, the more important thing I would like to say is we are still negotiating. She is almost become part of FACEMI, I should say. I think the way she has been, she will lose her identity very soon, whether she's from Government of Karnataka or from FACEMI. That is the, isn't it, Rajani? You will understand.
Yes,
That's the
ma'am.
kind of
Yes.
overwhelming experience she's facing with us. I'm so thankful to you. Only thing is, when your surname Parsarthy is, you know what Parsarthy is from the great epic Mahabharata. The battle in Mahabharata was won in 80.
Hmm.
Please bless us to win our battles in Government of Karnataka at least in 20 days. It cannot prolong and on. And I wish you all the best. My humble request is this 18 days Mahabharata war should be from today what you should remember with your surname. Over to you, Rajani,
Thank you,
Dr.
ma'am.
Rajani. And I have 2 questions for you, which can sort of give you the roadmap to whatever you would like to say. Firstly, how is this golden hour for mental illness put in practice in your daily routine? You are not just a doctor sitting in a clinic, you are more of an administrator, policy maker, involved in the implementation of the Mental Health Care Act, monitoring, regulating, so on and so forth. So, in this busy schedules, which is outside the clinic, into the community, I mean, amongst your government officials and so on and so forth, how do you handle this golden hour, and how do you think it is, and what is the kind of knowledge you can share with us, how you are implementing it? Over
Yeah.
to you. Yes.
So thank you very much, ma'am. Good evening, everybody. Thanks for the opportunity. And good evening to all the FaceMe members. It was so heartening to listen to everybody's talk. I think I joined a little early, around 3:20, 6:20. So basically, I think this is a good topic also. Little different from the routine topics what everybody keeps. Thanks to Nirmala ma'am, for such an innovative topic. So golden hour usually we talk about in emergency medicine, like if a patient with stroke, they have to reach the stroke ready centers within 2 to 3 hours, and the intervention has to be has to happen within 4.5 hours, and the cardiac arrest. So we are used to this kind of golden hour in emergency medicine. But in psychiatry, golden hour we can think of in various situations where the patient is either agitated, for example, acute psychosis, acute stress reaction, severe agitation, panic attacks, or severe anxiety, suicidal ideas, or even suicidal attempt, and then severe depression, manic episode with severe irritation, anger outbursts, and then impulse control disorder where it is extreme situation. So how do we narrate this golden hour? Maybe early diagnosis, and then early reaching to the mental health establishment or any public health institution or any health institution or any mental health professional, like basically they establish safety of that person, build trust and a therapeutic alliance with the person, conduct rapid assessment, and then the triage and stabilization, and then communicate very clearly with the family members and the patient. So like madam was telling about the 108, where one of the good 108 services wherein they are catering to the mentally ill people also. And then to give an example, what we are trying to do now is whenever there is a call for 108, we are just thinking whether those calls can be routed to telemanas to quickly triage the person with mental illness. How what is the harm that the person can cause to himself or the others, he or she, and then can telemanas triage them, then can they coordinate with the 108 and police under section 100, which is their mandate. And also if we can we train the health team thoroughly with the emergency medicines like haloperidol, lorazepam, mouth dissolving risperidone, clonazepam. So a set of drugs which can be kept in 108, and a nurse who is trained who also goes along with an attender to the person with mental illness when there is an agitation, and whether the entire team can manage and bring the person safely on time to the mental health establishment and give care at the earliest. This is what we have been thinking, and I think we've been discussing with the legal advisors also, and soon we will come out with an SOP is what I am telling you. And also like to give you an example how we have handled, I think n number of cases are there. So last year I think around 11 o'clock, the previous chief secretary called me telling that one of the staff from one of the government offices, he was very frustrated. He had written a letter to police commissioner telling that he is going to attempt suicide that day because of some stress, which I don't want to narrate here due to the confidentiality. And then immediately I called that person, and then I routed telemanas doctors called that person. They were engaging him, they discussed with him various coping strategies, and then within about half an hour he was much better than what he was. He was brought back to reality from his distress level, what was there. So we could avert this suicide attempt which he had planned elaborately. And next day it was so heartening from that person that he had messaged me telling, madam, after the call from telemanas team and the doctors team, today the district mental health program team also visited my residence, and they have given me whatever care that was needed. So this is how we had managed one of the cases, but of course n number of cases are there like this. That's it for now, ma'am.
Thank you so much. Just Saraswati, can I just, since she's in a hurry, can I just ask her a question before she leaves?
Yes.
Just one question.
Yeah.
Dr. Rajani, just a question from what you say. Amazing work you're doing. I just want to know what it appears to me that it is being handled. That is treatment in emergency treatment, medication, injections, or whatever is to be given. You mentioned a couple of names, haloperidol and other injection names and all.
Yes.
It is being done already to psychiatry, but only the word golden hour is not mentioned.
Yeah. This is a new
Probably,
thing.
I think
Yeah.
that word will also give the importance and urgency for psychiatric patients. And I would urge you to just make it a very, give a recognition to this, the whole thing which you are discussing now, whether you triage it through telemanus or otherwise, directly handled as emergencies. Make this golden hour an official word so that it gives the significant, drives home the urgency of the matter to the staff handling it. That is my humble request. And I'm so happy, whether you like it or not. I'm very proud of Maitri. We initiated this discussion with Government of Karnataka, and if it is culminating into a policy decision as well as a government order to follow practice, we'll be very grateful to you. Dr. Rajani, please keep us informed about the process of, and also the outcome of this initiative that you are doing.
Yes,
And
ma'am.
also,
Once these circulars are out, definitely I'll
yes,
share those.
definitely use the word golden hour as a
That I am not a policy decision maker, ma'am. You can write a letter to the policy makers,
Yes,
and then
yes.
we will see
We'll be
what
in
they
touch
guide
so
us.
that you can guide me where to whom to address. And then, because once it becomes a precedent, other states are also important. I think the importance should be given. Thank you so much for
Yeah,
joining
we
us
can
today.
also take inputs from NIMHANS, ma'am. Then we
Yes,
can see
definitely.
how to go about.
I think Dr. Krishna Prasad is present here, and this should be taken forward either as a discussion by NIMHANS or by Government of Karnataka, which can culminate into official policies and decisions, not just a brainstorming session. That won't help. It's time golden hour is recognized. Thank you so much. That is
Thank
the
you, ma'am.
conclusion I draw from our first panelist, Dr. Rajani. Now we go on to our second panelist, Dr. Krishna Prasad. Dr. Krishna Prasad, first to begin with, my apologies for keeping you waiting for so long. Hello.
Yes, ma'am. I'm here, ma'am. No problem. Please go
I'm
ahead.
sorry that we have to keep you waiting for so
No
long.
problem, sir. No problem.
But it is always, we feel all of us feel very comfortable having a psychiatrist always around us. It gives us almost the divine presence. That's what we feel when a psychiatrist is with us. Thank you so much. And I would like to have the pleasure and privilege of introducing Dr. Krishna Prasad. He is currently Professor of Psychiatry at NIMHANS and is currently helming the Psychiatric Rehabilitation Services DPNR in NIMHANS. He has completed his MBBS from Bangalore Medical Colleges, specialized in Psychiatry MD from NIMHANS. Previously worked at AIMS, Bhopal and CMC Vellore. He has more than 50 research publications in peer-reviewed journals. His area of interest are rehabilitation, emergency psychiatry, old age psychiatry, and gatekeeper training for suicide prevention. Above all, he is a well-wisher of FACEMI and my mentor for things that matter most and in the mental health domain. Thank you so much. We can't have a more competent person to handle this session with your expertise in emergency psychiatry as well as in suicide prevention. Over to you. And I have a few questions. I'm sure you'll do the needful in your presentation. But the question is, do you think, yes, what exactly do we mean by golden hour in trauma care?
Okay, ma'am.
That is, what exactly, DSM doesn't give us a definition. Can you give a definition? And what will your definition describe what is the treatment process? not just in trauma care, but other places, scope for application in other aspects of psychiatric emergencies and psychiatric treatment. That is something which I would like to know from you. And how is golden hour for MI is put into practice, if at all that word is recognized by psychiatrists?
Okay,
How
ma'am.
can we, yes.
Yeah, ma'am. At the outset, I think I would like to congratulate FACEME for, serving the community in terms of the family members for 10 years. And uh,
Thank you, sir.
congratulations for being a support forum for all the family members whose loved ones are affected in one way or the other. And I think significant voice for the group, because I think in many other areas of disability, I think there is a whole lot of uh, pressure group that is there. And I think in many ways, I have felt that FaceMe has been able to kind of deliver that as far as mental illness is concerned. And I think um, our director of NIMHANS has a direct contact with Dr. Nirmala, and many of the policymakers listen to her and heed her advice. So I think in many ways things have changed for the better. So congratulations once again. Now,
Thank you so much.
so I think in terms of golden hour, when we are speaking about golden hour, it is generally used in the context of medicine. I think Dr. Rajani already mentioned that this is in the context of conditions like stroke, or sometimes in the context of road traffic accidents, or in the context of uh, care for very small children, neonates, that it is used, or sometimes even in the context of orthopedic injuries. So, whereas this term probably has never been used really in the context of mental illness. Now, when we say golden hour, it means that this is a time when any intervention given is likely to make a substantive impact in terms of morbidity or mortality. So, it may be a window of 1 hour, it may be a window of 3 hours. That provides us this window of opportunity to intervene and substantively reduce disability or reduce the chances of death. It becomes little difficult to define this in the context of mental health. Uh, Another term which is often used in the context of mental health is duration of untreated psychosis, and this is in the context of especially schizophrenia that this term has been used. And when we see people coming for seeking mental health care, it is after a long duration sometimes that we see. That is sometimes after 3 years, after 5 years, after the symptoms have started. Either the family members or the well-wishers have never noticed the symptoms in the person concerned, and it's only when the symptoms become really florid that people are brought for treatment. And what is well known is that longer the duration of untreated psychosis, the lesser the chances of clinical recovery, lesser the chances of response to treatment, and a whole lot of negative symptoms that kind of are go unnoticed in the beginning may also mean that the chances of recovery become guarded or less optimistic. So I think this is what is more really understood in the context of mental health, especially in the context of severe mental disorders like schizophrenia or even bipolar disorder. In the context of bipolar disorder, a depressive episode may be missed, and it is only in the context of a manic episode when the person is extremely aggressive, or when there is a major legal or a domestic issue that develops, that is in the context of which things happen. So in many ways, then it is not really golden hour. It sometimes is the golden years that get lost. So I think that is one of the issues that we see in mental illness. But I think having said that, we also need to understand that, like Madam mentioned, Nirmala Madam mentioned in the beginning, the experience that people have in the context of the emergencies that people are brought to a mental health setting. I actually worked for a year in the emergency at NIMHANS between 2012 and 13. And in retrospect, and even while I was working there, what I felt is that the experience both for the service user as well as for the family member could have been far more gentler, could have been far more softer. Many things that we could have done need not necessarily have involved medications. The nature of the setting, the volume of the people that come there, the training that the staff and the support staff have there, all of that could have been different, is what I feel in retrospect. So I think the challenges that the families have in terms of bringing the person to the hospital, sometimes in the middle of the night, the difficulty in arranging for ambulances, the difficulty in transporting people for treatment. I think all of these. Um, Actually, if you see people who over a period of 1 year are only actually seeing, I mean, facing these kind of difficulties, it was a little disheartening for me at that point. So I feel that systems that FACEMI and the government of Karnataka are trying to kind of develop towards these are important in not only really in terms of improving the mortality or morbidity like it happens in medicine, but I think the entire experience of a mental health system should actually get better. And in many ways, uh, the prognosis of anybody with severe mental illness is determined by the kind of relationship that the person shares with the mental health system. So if the experience is not positive, if the experience is extremely negative, then the trust in the system and also the trust in the therapist reduces, and that this kind of uh, it does not bode well for the outcome. And the outcome is leading a life which is meaningful and uh, where the person sees hope. So I think it is to that extent that I think the experience that people have in the mental health systems, primarily in the emergency care, that needs to get softer. Maybe not always pharmacological. There are other ways of dealing with the difficulty. Staff need to be trained. So these are some initial thoughts that I have. We don't usually get as many post-traumatic stress disorder patients at NIMHANS. It is more a high-income kind of a phenomena. Of course, now all care is trauma-informed because a lot of uh, uh, we have seen a changing society and increased recognition of different adverse experiences. So yeah, I think these are some initial thoughts that I have. The fact that in at least severe mental disorders, there is this issue of a long duration of unrecognized, untreated illness. And the second point is that emergency systems can be much more caring, much more softer in the way both with the service user as well as with the family. I think these are things that can be done for the better of care.
Thank you so much, Dr. Krishna Kumar. Saraswati, we want to take questions for him now, or let Sumit also finish. What is the?
You can take questions because Dr. Krishna Prasad has to leave by 7:30.
Okay. So I'll just, from what I noticed, a very brief and very concise and the clarity of golden hour. Golden hour is not so much to be used. That's the message I get. He said not golden hour, but golden years. Please mark it. It's almost coming as a sermon from the mount for the families. Early intervention. So far, if I've understood Dr. Krishna Prasad correctly, there is not one particular incident that marks golden hour in psychiatry, but through the entire life cycle of this person, the person who needs treatment or is under treatment, and especially early intervention. This is what we are working with Government of Karnataka, and this is the reason why he is also heading the assisted home care project in NIMHANS. Can you please bring Dr. Krishna Kumar on screen here at Saraswati?
They call it the golden period.
Yes, questions
It can be a few months, it can be a few weeks.
Amritji, please ask your questions to Dr. Krishna Prasad before. Yes, please.
I think he also must have listened. Dr. Krishna Prasad, are you there?
Yes. He's there.
He's there.
Yes, sir, I'm there, sir.
So what I was suggesting was that you use the right word golden year, but instead of that, if we call it golden period, the initial stages, if the treatment starts, then recovery chances are much, much better, and aggravation will not take place. So we can use the term golden period, which may be a few weeks, it may be a few months. Earlier period can be called golden period. That's just a suggestion, which I thought will cover the intention that immediately the treatment should start. If some emergency arises, then also it should be immediately attended to. So that's just a suggestion. Thank you very much for coming and enlightening us with your valuable views. Thank you very much.
Yeah, I'll just
Any
add
more
up.
questions?
Yeah, ma'am. I'll just respond to that comment,
Yes.
ma'am.
Please.
I think it's important to realize that when you use something like a golden year or golden period, it is perhaps not as attractive as golden hour, because then it kind of golden hour kind of gives you a message that it is this critical hour, and it is during this critical hour that you are able to save somebody's life or turn the tables in terms of the outcome. So I think there is this important message that golden hour or golden hours give. But when it comes to years or period, I think it becomes a little bit of a challenge to convince somebody about it.
Mental illness, the golden hour will be relevant only in case of attempt to suicide.
Suicide, yes. So that is where I was trying to come, that suicide is
I beg to
perhaps...
disagree. I beg to disagree a bit, not fully. I beg to disagree. We need to have this golden hour concept, at least emergency crisis handling and shifting patients in the ambulance.
Yes, ma'am. So that's where I was wanting to say that
it is a nightmarish.
Yeah.
Just
yeah.
yes,
True.
that period, forget about the families may not have had the opportunity all over the years or golden period, and that we cannot take that into consideration. But at the time of shifting a patient in an ambulance, whether private ambulance or if it is 108, I think some first aid in terms of medication treatment injection should be given at par with stroke patient or cardiology. What do you think of this? It must be made, and it is also in the Act. If you see Section 21.4 of the Mental Health Care Act, it says equal to those in physical illness. Those with physical illness get all medication first aid treatment in emergency. Why not this?
Yes, ma'am.
At that time, at least we have to use the word golden hour in a restricted way, so that to train this staff, sensitivity of the staff members. Please respond.
Yeah, ma'am. I agree. So it is perhaps applicable in the context of psychiatric emergencies, and it is particularly applicable, as sir was mentioning, in the context of somebody suicidal. So one of the things that we have been doing is to train lay people included in terms of identifying early warning signs of suicide and how to respond to somebody who is suicidal. So this is something that as a part of the gatekeeper training program, we have been doing at the NIMHANS Center for Well-being, as well as also now the country, since has a national suicide prevention strategy, has also been looking at preventing youth suicides. So in that direction, the Indian Council of Medical Research has actually asked for looking at gatekeeper training as one of the methods of identifying suicidal persons, and also to respond immediately. So I think in the context of suicidal crisis, as well as in the context of other psychiatric emergencies, it can be it can be used. It has potential use.
And
But the purpose perhaps would be to make the experience of the management of the situation to be more easier for the family, more easier for the person concerned, and also to ensure that the services don't really kind of create trauma for everybody concerned. So
yes,
I think many a times I
that's
noticed
another.
that the entire experience
Yes,
is very traumatic, and
yes, which could be
perhaps
minimized. Yes,
it leaves kind of a blemish for a long time where people don't want to use the service. I think we should strive towards making the services more sensitive, more where strategy is not necessarily only pharmacological. De-escalation can mean the way you respond to a person who is agitated or
absolutely.
irritable
Yes.
need not necessarily always be pharmacological. So I think this is something that we feel that can be inculcated in training during the training of the staff, be it doctors or be it paramedical staff or nurses. So I think these are some things that should also happen where, as a part of first aid or as a part of first response, this should happen.
Thank you so much,
We will
Dr.
have to
Prasad.
identify the situations where we call it golden hour. If there is a need for supported admission, is likely to do self harm or harm to family members, and has to be rushed.
So
Therefore,
yes, Mr.
uh,
Bakshi, we have to. I'm going to extend a formal request to Dr. Krishna Prasad before we close the session that they work with us and identify such situations which can become a policy by itself, not just training people. It should become a policy, and if necessary, it should be practiced in the first aid given to ambulance, emergencies, all those places. So we have three concrete cases. Lot of clarity has emerged. Thank you so much. One is the involuntary admissions with supported accommodation. That is also possible, as Mr. Bakshi said. The other is emergencies, and also most important, trauma cases and suicide cases. All these cases, if I understand, golden hour is mentioned. Thank you so much, Dr. Krishna Prasad. Thank you very much. And over to our speaker, the last speaker in the panelist, Mr. Sumit Guha, is a graduate. Sorry, Sumit. Is a graduate of the prestigious IIT Kharagpur and has a diploma in management from IIM Ahmedabad. He is a member of the Tata Administration Services, the management cadre of Tata Group, and has held senior positions in well-established Tata companies. He left the Tata Group in 2015 as he could not function due to an episode of mental illness. He has been volunteering with FACEMI since December 2023. As Senior Mental Health Advocacy in Charge, he has handled several assignments in FACEMI. Few among these are preparation of proposal for mental health improvement for West Bengal government, concept note preparation for Niti Aayog presentations, helping FACEMI with VCs, all virtual conferences for presentation to state governments and health officials, SOPs for 108 ambulance, and development of e-Kutum app as part of the team that worked on it. Co-authored with me this report submitted to NHSRC with Delhi on the introducing rights-based services in mental health systems. Most recently, he has prepared a list of private hospitals in Bangalore with all the tariff rates and other things. This is going to be very helpful, I hope, across the model that he has adopted. We'll share with the rest of the group. From drafting proposals to resolving any problems, Sumit is the first name that comes to my mind for seeking help. Immediately, any time of the day, I forget the fact I cannot disturb him. I just don't have to even register it. I just pick up and ask him, and he's always been very kind and obliging. Over to you, Sumit. My personal thanks to you for accepting this invite. I have two questions to you, Sumit, before you start. Firstly, with your personal experience and extensive reading on the subject of mental illness, especially schizophrenia, how do you see Golden Hour as a social intervention, particularly for assisting PMIs living in families, in workplace, or even in colleges and schools? Do you have any suggestions to promote and protect the rights of PMIs in golden hour as recognized formally by the profession beyond trauma care? How can you help the families achieve this? Over to you, Sumit. Thank you so much.
Thank you, Nirmala ma'am, for giving me this opportunity to participate in this panel discussion. When I first heard the topic, I was a little surprised because I had never heard of the golden hour in psychiatry. I mean, the more common thing is duration of untreated psychosis, which I think I have personal experience because for about 4 years in my third episode, I wasn't treated because I didn't go to the doctor because I thought everything was okay. And it's definitely taken a long time to recover. In fact, I'm not fully recovered right now. I still have a lot of cognitive impairment, but I'm doing whatever I can to handle the situation. Basically, on the golden hour in psychiatry, I think the only thing that we can compare it with is to call it timely intervention saves lives. And basically, I agree with Dr. Krishna Prasad. Golden hour in psychiatry cannot be compared with the golden hour in a stroke or emergency medicine, where there are stroke clot busting drugs which are used to within a certain period of time, and there are no such drugs as far as I am aware in psychiatry. But golden hour in psychiatry can be used to say that early intervention in crisis leads to better outcomes, sorry. And borrowing from trauma care, the first hour is critical. Basically, why golden hour matters is because it prevents suicide, harm, or aggression. And this can be very useful in these cases, particularly, but not general psychiatric cases. So they're really for psychiatric emergencies. It also reduces rapid deterioration of the patient if it's treated well in advance, and if it's treated in the acute phase, then the likelihood of recovery and long-term prognosis for the illness is much better. Early intervention creates early trust and results in a therapeutic alliance between the patient and the doctor, which is very necessary in the case of psychiatry because trust in the doctor is very important. And therefore, golden hour makes a difference in case of creating early trust and therapeutic alliances. The key situations in which golden hour can be used is in suicidal crisis, or in first episode psychosis, or in acute mania or severe depression, or substance intoxication or withdrawal, and at a time to reduce agitation and violence. Basically, early intervention reduces agitation and violence in the patient and prevents any kind of harm either to the self or to the surrounding people. The principles of golden hour are very rapid assessment. It will be very important for a quick assessment to take place. Safety first is the primary goal of the golden hour. Safety to the environment, safety to the staff, and safety to the patient. Stabilization of the patient, verbal de-escalation, and medication if needed is an important factor in achieving the aims of the golden hour. Engagement in terms of empathy from surrounding people, the family, and the hope to the patient for the golden hour is very critical. Referral and follow-up is very important, and continuity of care is very important. Early intervention services in psychosis is something that is important in terms of wider applications. Community awareness and primary care training is important. Reducing treatment delays is something that will be the aim of the golden hour. And a public health approach to the crisis care is something that is important for achieving the aims of golden hour. The challenges to achieving this golden hour are basically the stigma that goes into meeting a doctor for seeking help and even acknowledging that help is required. In my case, for example, I mean, it wasn't stigma, but it was just for 4 years I didn't seek any help from the doctor, and I think that has affected the time that it is taken to recover from this illness. Limited psychiatric patient emergency services are a challenge in achieving this kind of a psychiatric emergency survey, achieving this kind of a golden hour. Inadequate training of frontline staff in terms of providing them with the medication, providing them with the knowledge of what to do, and coordination gaps between psychiatry and emergency medicine are something that is very important. The golden hour in psychiatry is an opportunity to save lives and shape recovery, but as Dr. Krishna Prasad said, it is not everything. Timely, compassionate, structured care is vital in psychiatry as in trauma care. So that's basically the takeaway from this presentation. And this is what I thought I would share with you for the purposes of golden hour.
Thank you so much, Sumit, for your golden words. Absolutely makes sense. So what I've gathered from the speaker, from you, actually is the scope for application is there in various aspects of psychiatric illness, the life cycle, starting with early intervention is what we have to emphasize. And that early intervention is the biggest challenge that families are facing. As you said in your case, on an average, it takes 3 years on an average for the families to recognize and believe that it is an illness and seek help, notwithstanding stigma and other things. So that moment of golden hour, when we, even after 3 hours, when we go to the doctor, first visit, when the diagnosis is done, I don't know how many families really trust the psychiatrist. So the trust is another thing which you highlighted. Yes, there is an illness, let's take the prescription, buy the medicine, start the medication. On the contrary, most families start headhunting for another psychiatrist. Could this be really true? This has happened in several cases, including mine. Not accepting the diagnosis. So early intervention itself, when it beats the consultation, then we have another second phase. Aftermath of early intervention, we meet the doctor, but then that gets again prolonged phase of mistrust, headhunting, going to different psychiatrists, and then comes faith healing and other non-medical beliefs and practices. So golden hour, I believe, will give a push to all these aspects, a comprehensive terminology to take care. You talked about trauma, including trauma. Right now, it's only applied in trauma. And Dr. Krishna Prasad, as he mentioned, he also mentioned early intervention. And I'm insisting on emergency ambulance shifting, where medication is to be given, apart from medication and other things. So with this, Saraswati, any questions you can now ask the time.
Yeah, so there were three people who had raised their hands.
Yes, yes.
So Venkatesh Prasad ji, would you like to ask your question?
The two doctors have left, by the way.
Yeah.
And will I ask Sumit? I hope you have some time to answer the questions. If there are questions to you.
Yes,
Sumit?
sure.
Yes. Yeah, thank you. Saraswati,
Venkatesh
please.
Prasad ji, would you like to ask the question? You have raised your hand.
No, I don't have a question. I have a suggestion.
Yeah.
In fact, I have been, as you are aware, I have been practicing batch flower remedies for the past 34 years. And one of my earliest experiences
Saraswati?
was,
Venkatesh ji, if is it related to the topic of golden hour?
it is related to the topic, madam. I'll just tell you the real lifetime incident which happened in my case. In 2013 August, there were ethnic riots in Assam, and 70 children, age group 10 to 15, boys and girls, their parents were brutally murdered in front of their eyes. What more can be traumatic in a person's life? And the NGO guy came running to me. He said, those children know only Assamese. They don't know Marathi, Hindi, English. I don't know how to take care of these children. So I prescribed some flower remedies from batch flower. And then I said, rest you leave to God. He will take care. After 3 months, he came singing like a lark. And those children were artisan children. They gifted me a beautifully
Very
carved
nice.
jewelry box. So
Very
what I am
nice.
saying is that allopathy doesn't recognize batch flower remedies. They say there has to be an article in Lancet, there has to be peer review, blah blah blah, all those things. What I am saying is cherry plum will help in suicidal prevention, and rescue remedy will restore the frayed nerves of the caretaker.
Okay.
So
Thank you
if that
very
can
much,
be
sir,
kept,
for your information. I'll now, because we are we are falling short of time. Sorry to
sure.
interrupt
I have
you,
made my point.
Venkatesh.
It is
Thank you
up to
so much.
allopathy. It is up to the practitioners to follow this or not. It is their call. I
Yeah,
will follow what my mind says, what my
no problem,
conscience
sir.
says, and
Thank
my
you.
experience. Thank you so
Thank
much.
you for sharing your experience, Venkatesh ji. Now Prashant ji had raised his hand. If it is related to the topic, please ask the question, sir. Prashant ji, you can unmute yourself and ask.
Hi. Yes. So my question was regarding like what doctor was saying, that we can focus more on non-pharmacological options, as well as making it more pleasant for the person, so that the trust building will happen. Like in the smartphone, we say that there is a way to enter the information for emergency. Typically we'll enter blood group and any allergy to the medication. So that part is there under medical notes. We don't have any other option to say about like what is there in advanced directive, or what should be the accommodations or accessibility issues that the person needs. So along with that, what else can we add as a part of something which will help in the golden hour, right? So my question is regarding, for example, in the smartphone setting, there is a way to enter emergency information. What would be the points the doctors or the panelists will suggest that we should include in the emergency setting that is related to golden hour? For example, if there is something that is some specific music that person prefers to have a soothing effect, or something uh, sensory overload that can be taken away, those kind of things. So just wanted to get those inputs from the experts. Yeah, whenever they can. Thanks.
Sumit, would you like to respond?
I just think that the patient who is going through a trauma is not going to respond in this way to add on a kind of a soothing music and all that to is the app at that point of time.
Right. That's why
tend
the
to
question about
agree with
entering that beforehand.
You mean anticipate a trauma and do it? Do you mean that?
Whenever we enter emergency information in our phone,
yes, this is something
same
which
way,
there is a
or
question.
like we write advanced directive. So is there a specific format
Advanced
that we
directive
can
is very
suggest?
important. whether in a trauma emergency or regular admissions or even voluntary admissions. It is the duty of psychiatrists to ask for advance directive, though it has not yet come into practice yet, in India to the best of my knowledge, but it is important. Apart from that, to see the prescription, whatever medicine that patient is being given. The most important thing, if it is recently, yesterday, Saraswati, in fact, in the latest podcast she did, lies on psychiatry. The most important thing in trauma also is if the patient has any physical illness, the doctors should not learn how to liaison with the psychiatrists. In the trauma, in the ICU, they should not stop psychiatric medicines, which happens quite often. So the psychiatrists are not able to continue this. There are many more things. I think we should have a full-fledged workshop on this. I will try to talk with Dr. Pratima and NIMHANS, and that also with Krishna Prasad or with Govt of Karnataka. Let us have a kind of a workshop for caregivers on this. And also let us officially push this word golden hour first. That is my concern. Unless we advocate for it to come as an official circular, let's not split hairs about it. Academically, we can discuss many things. Officially, we have to, that is the conclusion. I would like to ask all the family members here, please, you will guide. FACEMI can guide for you to write to various people. I don't know how Sumit feels about it. Any more questions, please? Sorry, I don't want to take up Sumit's
There is that we'll take the last one, which is Mr. Bajrangji. Bajrangji, is this related to the topic?
It is regarding golden hour. I would like to support golden hour word, not golden period or golden year. Because I would like to say from my experience, because in 1986, I was taking innuendo and all these things. My family, my sister and my brother-in-law took to family physician, and he has given me the injection. I could not recover. Then they told that if he does not recover in the night, because it was in the evening, then you take to the psychiatrist. He has given number and all these things. In the morning, after night, in the morning, I was doing all odd things. I was going to the neighbors and all these things. So they have taken me in the car. There was car with my sister and brother-in-law. They have taken me forcefully in the car. They have taken me to the hospital in psychiatrist. And psychiatrist, I told that he wants to kill me. He is giving injection of the killing. So I can't take. So I was violent. And two people had stopped me by taking my hand, and they have given me injection. And then after few hours, I woke up and I do everything. I was in hospital for 3 days. He had prescribed me the medicine, only 2 medicines. I am taking for last 40 years. There was no left, and I have done the service also. I have raised my children, and they are CA, MBA, engineer, all these. And you see, if that golden hour of the taking in the car and going to the psychiatrist not have happened, then I would have been wandered in the road, and I would have been like pagal, and my children would have been beggar. So it should be the golden hour, not the golden period or golden year. It should
So
be
it is
the
the golden
hour.
hour of a psychiatric emergency. Basically, this is what we are saying. The golden hour applies in the case of psychiatric emergencies.
So it was emergency. It was not suicide, but it was avoidance of the wandering to the road.
Very relevant point.
Very relevant point, sir. Thank you
Not
for sharing.
just suicide, but other.
So that's what even
emergencies.
Dr. Krishna Prasad said on
Yes.
psychosis, when it is not only suicide, but also he covered psychosis, especially like in terms of
Saraswati, I think we should prepare a sort of a summary note, white paper sort of a thing, circulate along with the link when you publish the link to the various groups.
Only 2 minutes. Appreciation.
And Mr. Gopal Krishnan is also waiting. Saraswati?
Yes.
Appreciation of the program is this, that I really love this program. I've written in my chat also. These are the golden hours for me.
Yeah.
These are
Thank you so much.
Thank you so much.
You are the golden people, golden water angels, whatever you say. See, I am now recharged. I have again regained my energy and motivation and this one. So I will never forget. So I request you to conduct so many golden hours. Many
Thank you so much.
pearls and many and Nirmala ma'am, I learned from you also so many things. Because of you, I have taken a leadership in advocacy. That's all.
Thank you. Thank you.
Thank you so
Thank
much.
you.
Thank you.
Thank you very much.
So the
Yes.
last question,
Please, yes.
Sadashiv ji had raised his hand. That's the last question I'm taking. And then I'll ask Gopalakrishnan to say a few words before we
Thank you.
Yeah. Sadashiv ji, if you can unmute yourself.
Yes.
Yeah, you're
Just one question to Mr. Sumit. Apparently, yes, is there still?
we're not audible, sir. Can you please
The
talk
thing
a
is,
little louder?
Yes.
able to hear me now?
Yeah.
Yes.
yeah.
Now this is better.
Golden hour is being talked about in terms of timely intervention. But there are cases, it must refer perhaps to any impulsive outburst on the part of the patient, which may pose a danger to him or to the people around him. But there are, in my son's case, his impulsive activity, although he is a recovered patient from bipolar illness, his impulsive activity of coming to the help of each and everyone who is running short of money makes him run huge loans exceeding 20 lakhs. And it's a very impulsive action from one NBFC, non-banking financial company, at 30% and 40%, 40% rate. I have settled more than 20 lakhs so far. Now, this is an impulsive activity. And what you are talking about in preventing suicide is also an impulsive activity for the very day after that person comes and writes the deputy director, thanking her for this kind of advice. But what do you do in such? This is, I don't know whether it is related to the topic, but in this case, the golden hour, which is a threatening hour, extends to a lifetime of relative care and treatment, and the person is capable of self-care, he is very functional, he is attending his own duties and night duty and day duty, driving his own bike. But can we restrict impulsive outbursts, which are the hallmark of the threats posed in a golden hour, where the person is not yet in a capacity? Dr. Krishna Prasad said that there can be non-pharmacological intervention also. Whether that person is in a position to receive, ingest, and moderate his whatever is gripping him at that point of time, or in my son's case, all the time.
Nirmala, would you like to respond to his question?
Yeah, we'll first ask Sumit and then.
Okay, Sumit, would you like to respond?
What Mr. Swami is saying, Sumit, you'll respond and then I can take over from you.
I think that this kind of a long-term situation is resolved. I mean, it depends on whether he has a condition and whether that condition can be resolved. Like, for example, giving away loans to borrowing money to give away to somebody else might be a condition of mania, and that is a long-term situation which needs to be treated. So it has nothing to do with the golden hour, really. It's to
sorry to intervene, only to save the time for Saraswati. Is anything more you want to say, Sumit?
No.
I believe we are restricting the definition of golden hour by restricting it to only trauma and suicide. I agree with Mr. Swami. In fact, non-pharmacological interventions like the blows that are by a physical blow on your head is, to some extent, is like the symptoms, various symptoms. It's a blow. This symptom of financial, whatever you call it, indiscipline, spending so much, and not being aware of it. Probably the lack of awareness, lack of insights into what he is doing, to be treated as a symptom. So the golden hour should be shifted not event by event. We should look at the trees, the forest, not the trees. This is what I would say, Sumit. We cannot just say that, we cannot split hairs and say, oh, this is suicide, this is trauma due to some incident that happened in the past in childhood, or this is abuse in the family currently happening, whatever it is. It can cover the entire spectrum of psychiatric disorders and situations and can give a scope for understanding the situation better in a more comprehensive way. For example, if Mr. Shivaswami's son needs to be admitted for taking him for through a course of financial discipline, that's as part of therapy, financial counseling. There's some therapy like that, counseling for financial experts in discipline. So the golden hour here is when he has incurred the loan, heavy amount of 20. I know Mr. Shivaswami has been going through it for the last 6 months to 1 year, and he even told him to read chapter 2 of the Mental Health Care Act, whether he can take advantage of that legally to approach somebody. But what I would say, Sumit, it's worth considering, and then we have to push it. The entire, I think Krishna Prasad said golden years and not golden hour. Those are golden words. With, I don't know, Shivaswami, have we answered your question?
Got it. Thank you.
Yeah. Before we wind up, can I ask Mr. Gopalakrishnan? He wanted to say a few words.
He's not there, I think. Gopalakrishnan?
He's there. Can you? Would you like to say a few words before we end the session? We're unable to hear you, Gopalakrishnan. Maybe you can put in the chat box what you wanted to say. I now hand it over to Raghu to say the vote of thanks.
Vote of thanks and the pledge.
Yeah, vote of thanks will be taken by Raghu. Raghu? Yeah, thank you.
Yeah, sure. Namaste, everyone. Let me begin by thanking Dr. Krishna Prasad. I can hear some echo. Please give me a minute.
Wait. Something has started here. I'll stop it.
Thank you. Let me begin by thanking the panelists first, Dr. Krishna Prasad, Dr. Rajani, and our friend Shri Sumit Guha. Thanks also to our members who shared their very contemplative and philosophical reflections. Last but not the least, thanks also to the Soames family for their mellifluous rendition of the background music during the introduction. Thanks to all the participants for attending. And finally, no amount of thanks, no words are enough to thank Dr. Nirmala for everything that she has done for this cause. Thank you also, Saraswati ji, for organizing this wonderful program. Thanks, everyone. Have a nice evening. Bye-bye.
Raghu, I'll also like to thank Sindhuja, who was part of this right from the beginning, and she couldn't join us to take it forward, but she has been part of this program right here, and I'd like to thank for her.
Wonderful.
She started out at the beginning to take this forward.
Thank you.
And now going on to the pledge. I'll just
1 minute. Special thanks to Sumit. He's in fact traveling tonight. In spite of it, he has spent so much time for us. Thank you, Sumit.
Thank you so much.
Yeah.
So we, the members of Families Alliance on Mental Illness, pledge to support one another and other families in similar situations and use language which conveys love and respect towards each other and especially towards PMI. we shall strive to protect and promote the rights of PMI as enshrined in the laws of the land. On this day, we take this pledge to work towards the vision and mission of FACEMI. Thank you, everyone. And thank you for joining us, everyone. And thank you, Raghu, for also being the co-host and supporting us. Thank you, everyone. And
special thanks to Raghu and Saraswati for making this a memorable event. Thank you so much.
And happy birthday to FACEMI. And hope we continue bonding with each other for many, many years and supporting each other. Thank you, everyone.
Thank you. Thank you, Sindhuja.
Thank you. Good night.
Good night.